and reflect on what is my interaction with fathers when they come in to the office, and am I encouraging their involvement and participation in prenatal care? So as I look at that, the first time that I will meet the father is when they come in for the initial prenatal visit. I would say probably 25 to 50% of the time they are present at the initial visit. I have a confirmation of pregnancy visit with the patient. That would have been an opportune time to say, hey, make sure that when you come in for your next visit that you bring your partner so we can have this conversation together. And that would then cultivate that involvement from the beginning. The next time that I talk about the father is when we discuss Zika. So that's a hot topic right now. And so I'll talk to them about condom use and this and that and testing. And then they kind of, if they were a participant, they kind of go back to work. They have to take off of work to be present for these visits that are monthly, then every 2 weeks, then weekly by the end. So it's usually about 13 visits by the end. And so I may see them at the anatomy ultrasound, which is midway through the pregnancy, because everybody gets excited to find out the sex of the baby at that point. And then at the end of the pregnancy, when they're kind of like, okay, so what's going to happen? What do I do? So there are definitely opportunities for me to engage the fathers, opportunities that I have not been taking, and I thought about that. We really, as physicians, are not trained in that way. We're not trained to involve the partners, so that certainly is an area where we could improve, physician education. So then I decided, okay, well, let me look into what type of resources, or we like to do evidence-based medicine. So what kind of data is there out there? And first you kind of start with a Google search, and there's a few advocacy networks, there's a few websites and .orgs and things like that. But I was surprised there really wasn't. I did a PubMed research, I did UpToDate, I did all these different things, and really there was not very much data out there. So this is truly like an emerging field of study for us. Some things I did find were some interesting articles. So there was some information that there was a study out of University of Toronto that reviewed 36 studies, and they found that mothers were less likely to get prenatal care if the father did not want the child. There was also an increased likelihood of low birth weight in fathers who smoke. So we do find data linking paternal involvement in their wellness and health to neonatal actual true health outcomes. At University of South Florida, they found that fathers involved in partners' pregnancy reduced the risk of neonatal death. So that's death within the first year of life. And there's also a link to anemia and hypertension and other conditions that were increased if the partners were absent. In New Zealand, they had actually done a study of about 2,000 couples, and they found that central obesity, so their belly fat, in fathers was associated with a 60% increase in low birth weight, and that was actually regardless of maternal obesity. So you would think, well, the body that's carrying this pregnancy, that should have more of an influence, and we found that actually, even if we factored that out and removed that as a variable, that the father's health and obesity status was still an impact for these infants. And the reason that low birth weight is such an important outcome that we look at these studies is because that is another indicator of neonatal well-being and risk for other complications, including death as well. Their involvement of men in maternal health programs has been associated with increased use of contraception, which is important for birth spacing, which I'll talk about a little bit later, improved maternal health outcomes, and increased uptake of interventions to prevent HIV. And certainly Florida has a problem with HIV. We've now made that part of our annual wellness assessment, is that we offer HIV testing to all of our patients 18 and older, so every year. We know that the vertical transmission rate is about 25% with prenatal care and antiretrovirals during the prenatal course. We can reduce that to about 8%, and then actually then down to less than 2% if they get antiretrovirals during delivery as well. So we know that if we have an opportunity to intervene, if the fathers are being tested and they know their HIV status, that is also going to majorly contribute to these outcomes. And then I found that there's ongoing research in something called paternal involvement and engagement. So that's definitely something that's new, and I think that this town hall, we're certainly at the vanguard of all of that, because there's very, very little out there. And I know that if it was that difficult for me as somebody who's trained to research these things, and I'm just having such a hard time finding information, certainly a father who has just found out that they're expecting a newborn and they don't know, how is this going to impact me, what can I do, how can I be empowered? There's very, very little out there, and I think that this is definitely a good chance for us to find ways that we can empower them and bring that information to them in a way that's accessible and a way that they'll be open to it, because like you're saying, there's a lot of cultural barriers that we face as well. Just to share like some personal stuff as well. So my father is a priest, and we're Caribbean, and I would have conversations with him about, kind of like mental health status and things like that. And in our family, we've been, been touched by depression and anxiety and things like that. And it really has been a challenge getting people to open up and discuss those things. The church didn't really recognize psychiatric conditions until maybe about 50 years ago. And as we know, maybe officially they'll make a statement, but even still it takes decades to kind of like overcome that. So if people are going to centers of ethics and things like that, and they're not getting that support there either, you can see how it's very difficult to change that behavior. So some other places where paternal involvement is very important in prenatal care. We always advocate it starts with preconception, so before we've even had the pregnancy occur. We want to know what is the status of substance abuse at home. Tobacco use, we know, has a major impact on neonatal outcomes. SIDS, sudden infant death syndrome, where we have a death that's of an unknown cause, we know is increased with tobacco use in the home. If a child has asthma and they have smoke or even secondhand smoke at the home, it increases the risk of asthma attacks and increase the frequency of those attacks. Genetics, a lot of times fathers don't realize we might want to test you as well. So the mother may carry a trait like sickle trait or thalassemia or something where we need to know the paternal genetics as well. That's often time where I find out that a father may not be involved or may not be accessible. And so then we're lacking that information and we're not able then to test the baby necessarily without being more invasive. And so that leaves a hard decision for the mother if she wants to have an amniocentesis, an additional procedure done. And then, if we're not able to diagnose these things earlier in the pregnancy, then we're discovering these complications at the time of delivery when we could have had a team ready to tend to the infant. So there really is, even pre-conception, a lot of involvement that's very important for us.